Hello and welcome to the ABCs of MIPS, our monthly broadcast looking at how merit-based incentive payments will impact your bottom line. I'm Carol Flagg of High Tech Answers. Thanks for joining us today. On this program, we address your questions covering the full spectrum of the payment program alphabet, including MU, PQRS, VBM, ACO, and more. On today's program, our questions center around MIPS versus shared savings ACO. Our expert, of course, is Tom Lee, founder and CEO of SA Ignite. Tom is a technology innovator and leader who brings his unique worldview and compassion to create health IT solutions for the business of caring for people. He's a national expert and thought leader on the incentive-based programs and initiatives. If we don't get to your question today, please contact him at tom@saignite. All right. Tom, I'm going to go ahead and control, and we'll see you back on the Q&A.
Sounds good. All right, well, great to be back. Wanted to start with some key takeaways from last month's webinar. We had talked about MIPS for the C-suite and looked at different parts of this key fact that winners are rewarded at expense of losers within the program. It's a budget neutral program, a lot going on within MIPS. And we also looked at different so-called elevator pitches, for motivating action in terms of what may be important to different members of that C-suite. So I encourage you to take a look at that perhaps later on if you'd like to see and get caught up. Now today, we're really going to explore this question, to MIPS or not to MIPS for those in the crowd, who are of a Shakespearean bent. One of the most common questions we're now starting to get is everyone knowing that under MACRA, starting in 2017, you basically are picking from two different tracks for Part B reimbursement. One is MIPS, and the other is under the alternative payment model. And one of the most popular possibilities for qualifying as an APM is to actually join or become a Medicare ACO. And in particular, the MACRA legislation indicates that if you are an ACO that is risk-bearing, that has downside risk, and that in turn you become an eligible APM under MACRA, then you would be exempt from MIPS and you would also get a 5% annual APM bonus. And then that really triggers a bunch of thoughts around, first of all, financially, what could be the difference between MIPS and any number one of these ACO programs to go alongside a lot of other considerations around what are some of the other reasons, maybe are non-financial, that may cause you to really go into an alternative payment model such as an ACO or other. So we're going to explore that question really from a financial perspective primarily, but we'll also look at some of the other dimensions for you to consider. And there's a sense of urgency here because the letters of intent to apply, they're due to CMS, are really due on May 2nd for the next generation ACO program and May 31st for the Medicare Shared Savings Program in order to be really deemed an active ACO by January 1st of 2017, which is when MIPS is projected to begin from a performance year standpoint. So there's a lot of organizations now that are really looking at the next 30 to 60 days as being critical to really figure out should they put those letters of intent in or not. It's a fairly timely topic. And again, if you want to get caught up more, we have all the webinars, including downloadable PDFs and videos on our website. All right, so let's look at this tail of the tape and how we're going to break it down today. First is we're going to recap MIPS as the baseline. We're also going to go through a bit of a primer on the Medicare ACO programs. And really from that base of knowledge, we're going to then look at a number of factors, or at least highlight a number of factors for you to think about in determining which one you want to be in come 2017 and how that may affect your decisions right now with respect to whether or not to apply to be an ACO or to be part of an ACO. And we're going to go pretty deep on one particular dimension, which is the financial dimension. And I've actually really been looking forward to this webinar because we're also going to be debuting right here live our latest version 5 of our MIPS financial calculator that actually has now been extended to also include estimating financial impacts of shared savings ACOs in the next generation ACO program so that we can really look and compare at how some of those financial impacts vary with quality and cost metrics across multiple value-based programs. So really excited to really show that to you all and get some feedback on that as well. All right, so let's start from the very beginning. Recap of MIPS starting with MACRA. Passed by a huge margin, puts Part B providers starting in 2017 into either MIPS, an alternative payment model, such as risk-bearing ACOs. Potentially, a provider could fit into both. We've covered that in some of our past webinars. That's an interesting prospect to consider. And there will be a small minority ultimately fit into neither, potentially first-year providers, so on and so forth. So this is really showing how that world of Part B really splits with the beginning of 2017. Now, how many providers will be affected? So for MIPS, there's various ways to estimate, but really we're looking at the vast majority of Part B providers receiving Part B payments falling by default into MIPS. MIPS is a way to think about MIPS is kind of like the default that you would fall into. Now, if you compare under the APM model, and right now the Medicare ACOs are by far the most numerous type of APM. Well, in order to really be exempt from MIPS and be deemed an eligible APM entity, the legislation currently says that you have to be bearing risk. And right now, if you just look at the ACOs, the Shared Savings Program, that are actually in tracks 2 or 3, which we'll cover in a moment, which are actually where they can actually share losses, not just savings. There's about 52 of those organizations now as of January, and something like less than 50,000 providers in total represented. So really from this kind of stat, and there's probably others that one could look at, really MIPS is kind of that new black or that new default for Part B. But nevertheless, there will be some important ways to really go on the APM track as well. So here's a part of that legislation. Again, this is something that there are a lot of organizations, such as the National Association of ACOs, that are keeping a really close eye on as the MIPS draft rule comes out fairly soon, is the actual language that indicates that in order to be a APM exempt from MIPS, to bear financial risk for monetary losses that are in excess of a nominal amount. Okay, so something for those of you who may know or are in or considering the Shared Savings ACO program, that track number 1, which is one-sided, there's a really big open question about whether or not there's really any nominal risk downside on the downside side. So there could be a possibility that those ACOs, which are the vast majority of current ACOs under Medicare, could also be subject to MIPS. Right? And that's potentially a big wake-up call for a lot of ACOs and something to really keep track of as the draft legislation, a draft rule comes out, and we'll certainly cover that again in future webinars. All right. Okay, so let's really kind of recap the specifics of MIPS. Starting January 2017 is the first performance year. It leverages the rules of existing programs, as we've discussed in prior webinars. It increases and consolidates financial impacts, and particularly the penalty adjustments. It ranks peers nationally and reports those scores publicly. Every MIPS provider will have a score from 0 to 100, or every group that chooses to report to MIPS as a group will have a score of 0 to 100. MIPS is budget neutral, as we mentioned before. The incentives to the winners are actually funded by the penalties that are applied to losers. And as a result, the difference in reimbursement between winners and losers can be quite substantial. And finally is that every MIPS point counts, where CMS is going to set a point threshold every year. Let's say if it were 50 out of 100 points, and for every point above or below that threshold, the provider will either get more money or less money. And that's in contrast to the current world, for example, of value-based modifier, right, which is your QRUR reports that I know almost all of you in provider organizations have seen so far, where there's this sort of fat middle, safe region, neutral region in the middle. And under the overall MIPS scoring system, that middle region turns from a stair-step plateau into a slanted line. And that has a very dramatic impact on how you think about the financial impacts and risks of MIPS versus what's come before it. Okay. Components of the MIPS scores. Let's just focus on that first year of MIPS. the first performance year, and you really have an outsized proportion that, of that MIPS score that is attributed to quality, the quality category, as well as meaningful use. It takes up 75% of the score. And as we've said fairly recently in other webinars, is this is an opportunity for you to optimize and really prepare for MIPS by doing things really today to get even better at managing things like PQRS, value-based modifier, and MU. And then the other area of performance are really resource use or cost, and we're going to come back to this in our analysis, has a lower weight in this first year of MIPS, but this actually goes up to 30 points by the time you get to the third year. And then also clinical practice improvement, new category of performance, includes things like medical home, weekend appointments, things like that, and that will be more clear as the draft rule comes out. Here's how the incentives and the penalties play out. Headline kind of says it all. You can see year by year, and we'll see this in much more detail when we get to the calculator, the financial impacts, which are based on this calculator. So that's MIPS in a nutshell. Now let's switch over to the ACO side. Now I know that ACOs can be a very complicated topic, and by no means is this going to be an exhaustive survey of every single nuance. But I'd like to try to accomplish the following, which is to give you all at least a sense for some of the levers, particularly the financial levers within the ACO program, that are important considerations, particularly when you think about whether or not you want to file a notice of intent to apply in or by the month of May. So let's really start with really kind of the granddaddy of them all, which is the Medicare Shared Savings Program, or the MSSP program. And the first thing is the structure of an ACO is important to understand, is that every ACO has its own tax ID or own TIN. And on the governing board of the ACO are required constituents such as certain leaders of the participant TINs. So these participant TINs on the ACO, they could be all within, originally within the same legal entity. They could be TINs that are in different legal entities that have come together to form this virtual organization known as an ACO. Okay? And so an ACO could have anywhere from 1 participant TIN to 10 participant TINs or even higher, depending on how many of these TINs have decided to come together under that one ACO's umbrella. Now, once the ACOs have aggregated and created this umbrella ACO organization, then what CMS is able to do for that ACO umbrella is to basically set a certain cost benchmark. And it's basically the annual Part A and B fully loaded payments to patients that were attributed to that ACO. All right, and we'll see this in a subsequent slide, and there's a lot of work actually being done right now to look at potentially making some changes to the way that patients are attributed. But bottom line is that there's a cost benchmark, and what CMS does, they measure the ACO's performance on cost by looking at what is the actual Part A and B expenditures that CMS had to spend on those attributed patients under the ACO. And then the difference between the benchmark and the actual either results in a savings to CMS or a loss to CMS. And then the extent to which the ACO can actually share in the savings or be accountable for the losses is to a large extent determined by the quality score of that ACO. And the higher your quality score, then everything will be more favorable to you as an ACO as far as getting more of the savings and sharing in less of the losses and vice versa. That's the kind of fundamental concept behind the shared savings program. And under MSSP, there are multiple tracks you can be in which actually define the way in which savings are distributed. Track number 1 is the one-sided case. So that is where there's only upside. You only share in the savings. If there's any losses in terms of benchmark versus actual expenditures, you are not accountable for those. That's one side. So that is the non-risk-bearing track. Then there's also 2 other tracks that are really defined in detail back in June of 2015. If you'd like to look at the final rule for shared savings ACO, you can take a look at that. But there is that they're both 2-sided tracks, meaning that there's both sharing of savings but also sharing of losses, and thereby they are risk-bearing. And these are the ones that are most likely to be considered APM eligible for the purposes of gaining some exemptions to MIPS, and as well as to get the 5% bonus, annual bonus. And again, the deadline is really coming up soon, particularly May 31st, for this program to put in a letter of intent to apply. Now, I want to really go a little bit more deeply into the attribution fee. This is one of the most talked about and sometimes least understood aspect of shared savings, and where there's been a lot of feedback from the ACO community about how it can be improved. And really comes down to this, is that every patient that's under Part B, at most, can only be attributed to one ACO. And so as a result, it's a really key thing to get right in terms of which ACO, if you have a patient, and let's say that patient is seeing providers who belong to two different ACOs, well, which ACO is quote-unquote most responsible for that patient? And right now, the ACO algorithm really uses as the metric the individual provider who has provided the greatest, the individual group of providers as identified by the tax ID, which TIN has provided the greatest amount of primary care services to that patient. And if that TIN happens to be a member or a participant in an ACO, then that patient, including all of the Part A and B expenditures of that patient, are going to be attributed to that ACO, and those dollars are going to be part of the cost benchmark that that ACO will be measured by. Now, there's all kinds of other things like risk adjustments. There's regionalization factors that are now being contemplated and even are part of this kind of ACO 2.0 revision, which I'll get to in a moment. But that's the basic concept of how the attribution happens. And that has some important consequences. This fact that all the Part A and B, all the inpatient ambulatory Medicare costs of each attributed patient, where now suddenly the whole ACO is going to be accountable really for all of it from a benchmarking and comparison perspective. And there could very well be many providers that are not even in the ACO that are accountable for those costs, or the ones who are actually sending in those claims. But that nevertheless, if that one patient in common is actually attributed to the ACO now is really being measured in terms of its cost performance based even on what other providers outside the ACO have done with the patient and have billed. And so here's a realistic example. We've actually seen this out in the field. So you could have an ACO that, if you look at all the participant TINs within the ACO and you look at all their Part B providers, in total they could be receiving $10 million per year in Part B payments. Just through the usual fee-for-service mechanism that all these participant TINs, let's say there's 10 of them, 10 participant TINs, are billing to Medicare and getting in return on an annual basis. But because of the ACO attribution mechanism, that ACO, if you look at the total Part A and Part B costs for the patients that have been attributed to that ACO, it could be something like $200 million on an annual basis. Again, a lot of those payments, this $10 million is only Part B, it's not Part A. But in addition, this $200 million not only is A and B, but it also includes all of the expenditures for those patients, regardless of provider, and if the provider was outside the ACO or not. So you could get things like a 20x difference between these two. And this is really a fundamental fact when you now go and you compare MIPS versus ACO, is that the payment adjustment and the way in which shared savings are calculated, these are the two fundamental numbers. And so the question is which will win out when I compare MIPS versus ACO? Will it be the MIPS share of this, or is it going to be the ACO share of savings or losses relative to this, combined with the fact that you could be getting an APM 5% bonus on this added to the shared savings of this if you were a qualifying ACO, that is deemed an APM. Okay, so don't worry, this is all being recorded. You can all go back and look at the web. There's a ton of information here, but it's a really important difference to really understand is the difference right here in terms of what is that amount of money that's actually being factored in to the MIPS financial calculation versus the ACO one. All right, we'll see some numbers here to really flesh it out. Okay, so that's the granddaddy ACO program, Medicare Shared Savings. The next generation program has come out really within the last 18 months or so, and there's probably about 20 to 40 organizations now that have applied and been accepted to the program. And really what it is that CMS learned a tremendous amount from the Shared Savings MSSP program, as well as the Pioneer ACO program that even preceded it. And as a result, they really went out and said, okay, here's a new type, here's some changes, okay, because we want to test out some new concepts. We heard that there's some pain out there. And there is first that for the next generation program, there's actually two different tracks, and they're both two-sided, meaning there's upside and there's downside risk, shared savings and shared losses. There is no option for only an upside only. Second is that there is a new cost benchmarking approach. So I alluded to before that there could be some regional risk factors. Right now the cost benchmark for Medicare Shared Savings Program, it doesn't really have a regional component, and obviously we all know that healthcare can cost very differently based on what part of the country you're in. The other thing that's really interesting with the Next Generation ACO program is that there is basically the ability to choose to have your cost benchmark given to you at the beginning of the year, of the performance year. Rather than the shared savings program, it's always been retrospective, where that benchmark was really not calculated in its final form until after the year was ended, and you didn't really have the insight into that cost benchmark until after the year was already ended. And so that has some really interesting possibilities as far as how do you financially model how well you could do in the Next Generation ACO program. CMS actually gives you some prospective benchmarking. The third thing that's really also interesting is that patients actually have the ability to choose what ACO they want to be attributed to, which actually can override that primary care services-based attribution that I talked about before. It's a voluntary choice they can make, and that can make the assignment of patients a lot more stable from one ACO to another. If it's clear that the patient wants a particular ACO, or the patient is more likely to say, I want this particular provider to be accountable for my care, most accountable for my care, and that provider happens to be a member of one ACO, then that ACO is going to have the patient attributed to it, for patients that go with this option. Okay. Now, the deadline to apply for this is basically, for the level of intent, is May 2nd. So that's coming up very soon, about 5 weeks away. And there's a lot more information on the CMS website regarding this. But I hope what we can provide in just a few slides may be informative in terms of how you want to compare this program to the other tracks. Okay, we're actually doing really well on time here. Famous last words. So let's now switch over and look generally, how is quality measured in these ACO programs? And first, and again, for many of those of you who've been following our webinar series, a lot of discussions we've had around PQRS reporting methods, value-based modifiers, so on and so forth. But for ACOs, it's very specific, is that in order to submit your PQRS quality measures, you have to use the GPRO web interface method in particular. And as many of you know, that method does not allow you to select measures. You are basically also, it doesn't allow you to select patients either. CMS essentially delivers to you through a website a list of a set of beneficiaries, patients, for whom, there's about 250 of them for every measure, for whom you have to go and extract the data that indicates what their numerators are for every measure. So that's really standard across the board. There's been some mention of CMS opening up some other ways of reporting quality, but those really are not finalized yet. If you go ACO, you're really going to be limited in the options that you have. There's exactly one way to report. You can't report providers individually. If you're an ACO, you have to use this one method currently. The second thing that's really interesting is that the quality measure benchmarks that are now used for value-based modifier that are likely to be inherited in large part by MIPS are actually different than the measure benchmarks that the ACOs are measured against. And the measure benchmarks are also updated less frequently than under value-based modifier, as well as likely under MIPS. And that's really brings some interesting situations. Is that, for example, in this current performance year, ACOs, Medicare ACOs, are also accountable for value-based modifier. And what happens is these PQRS measures submitted through the ACO program are also evaluated for value-based modifier. So theoretically, you could have a situation that, since the benchmarking is different, where your providers do well under the ACO program from a quality standpoint, but do not so well under the VBM program. We've actually seen this, where some of the top scoring ACOs for quality in the ACO program have ended up in the middle of the road with respect to value-based modifier. The cohorts are different, so on and so forth. Really interesting. Under MIPS, again, come 2017, there will be providers that fall both into an ACO, APM, and MIPS at the same time. And it'll be interesting to see how that dynamic plays out for those dual eligible type providers, because managing quality for them could be quite a challenge if you're being measured against two different yardsticks. All right, and we just talked about that, and we just talked about that. Okay, so now let's really start to get into this tail of the tape discussion. And here are some factors, kind of a laundry list of factors to think about. And there's surely many of you in the audience who even know a lot more about some of these factors than I do, but they are things that we do hear from our clients who do happen to be in the ACO program. First is obviously what we just discussed was your whole quality measurement strategy and the benchmarking. You know, how do you want to use those, use the benchmark? How do you, like, what kind of alignment or not with your own internal quality initiatives and strategy are really going to be imposed because of one program versus the other. Under MIPS, very likely you're going to have the full range of PQRS methods to use. Under the ACO program, currently is very restricted, as just one example. Another is the cost attribution to benchmarking. So if you compare in the ACO program that cost savings or loss piece and the benchmark that's used for that versus value-based modifier, which MIPS was likely to inherit much of the value-based modifier cost component and its benchmarking capabilities, is that there's definitely some strong similarities, you know, between what we would anticipate might be the MIPS way of benchmarking cost and attributing patients to measure cost, as opposed to the ACO side. But things are also changing on the ACO side, as I just mentioned, such as with the next generation ACO program. So that's something to just really keep track of, and you know, as you move towards potentially filing a notice of intent to be an ACO, or you get into the or subsequently you get soon into the application process, putting together your application, really interesting to kind of think about what kind of assumptions you should make about this cost dimension. The other is specialty versus primary care emphasis. So you can even see from the ACO programs I just described where the attribution is really based on primary care so far, for the most part, primary care plurality. You know, and that gives a certain emphasis on primary care with respect to some of these other factors above. Whereas under MIPS, you have the ability to even go down to an individual provider and say, I want this one provider to be my MIPS reporting entity. That provider is going to be able to report on their own behalf. And if that provider is a specialist, then there might be the ability to have a higher customization of measure selection and just generally how you optimize for MIPS for one provider, as opposed to trying to optimize an entire ACO. Okay, and that may be primary care, but they may also have other providers. So the other is, and this is a really big one, is the resource requirements and the coordination costs. You know, one thing that we've often heard is, you know, there's a big startup cost to getting any kind of ACO going, as well as maintenance costs. There's a lot of coordination costs if you have a lot of TINs that are from different legal entities. Interestingly, under MIPS, you also have some optionality there too. You know, you can form what's called a virtual group under MIPS, and you can band together practices that are less than 10 providers each, and that can also look almost like a mini-me ACO, if you want to look at it that way. And they can also report as a group and other things like that. So it's not to say that MIPS would be entirely immune from those types of costs, because there are some options within MIPS where you can start to incur similar type of costs, IT integration, so on and so forth. But it's just yet another thing to look at when you look at the overall picture, is how much it's actually going to cost for you to get it going, and then manage the administrative costs as well. This one's also an interesting one. You know, we've talked in our past webinars about how with MIPS, it really amps up public reporting, whereby consumers, through the Physician Compare website and then third parties repurposing that data, will be able to see the 0 to 100 point score for every provider even. Now in the ACO program, you can actually go on the CMS website right now, and you can Google this, and find it pretty quickly, where you can actually see for past years what is every ACO's quality performance. You can see what their cost savings was, whether they had any upside or downside, what track they're in, but you don't. But on that website, at least it's publicly reported, by CMS, you cannot really get to a provider level granularity. So, for example, the fact that the ACO program is using the GPro web interface method to report quality, that by definition means that from a consumer standpoint, they will not be able to see your provider's individual quality performance if that provider has basically been reported on for PQRS on behalf of the entire ACO. And so depending on your situation, that can be a hindrance to your goals from a consumer transparency standpoint, or it could be potentially beneficial, depending on what your situation is. Okay, now here's sort of the last point, and this is going to be a lead into this last section we're going to get into, which is around the financial impacts and compare in a comparative sense. And so just to kind of recap what I said before, is what we're looking at is, okay, under MIPS, I'm looking at a % adjustment due to the MIPS score that is going to be applied to $10 million of Part B. Okay, in that example I showed before with those kind of the numbers I put out in the prior slides. So let's say 10 million of Part B versus if I have an ACO model, I'm now looking at the $200 million of total attributed costs, for all the attributed patients, all their Part A and B, and plus a potential 5% APM bonus. So in dollars and cents, depending on my quality and cost, how do these two compare to each other? Okay, that's what we're going to get into right now. Okay, so let's do that. And before you all get too concerned about all the detail on this page, I just want to point out this is all in the free calculator. All right, I'll show you a resources slide later where you can get to it. We just uploaded it today, in fact, including it has a video as well of me explaining how to use it in detail. And actually, I go through pretty much all of these assumptions. Okay, and all these yellow fields are things that you can change, and you can see what happens. For today, we're just going to talk about a very simple case under the ACO scenario where that ACO only has one participant TIN. Okay, meaning that all of the shared savings that ACO goes is going to accrue to only one participant TIN. It's not going to be split among 10 participant TINs. It'll only be one, and then maybe a little further on, I'll talk about the implications of what if you do have 10 TINs. Then from the point of view of just one participant TIN, how would that be different? Okay, but for now, just focus on a one TIN ACO. It's the simplest possible ACO you can imagine. Despite all the detail, I just want to point out just a couple of really quick things. Is that here's where the $10 million comes along for Part B, is 100 providers at $100,000 each, and then here's that 200 million number I said in terms of the cost, the total Part A and B expenditures being the cost benchmark for the ACO. We're going to be now talking about a Track 2 shared savings ACO, which does have upside and downside risk. And then when we go to the next generation ACO, we will be talking about Track A, which is basically a sharing of 80%. 80%, it'll be grabbing 80% of the savings or the loss. Okay. All right. Let's look at some numbers. I know the reading's small here. Those of you who need to go on full screen mode, now might be the time to do it. I'm actually going to do the same thing on my side. So don't worry if this is an eye chart to you. I'm going to talk through this qualitatively, even if you can't read every single digit. What you're looking at here are the three scenarios of MIPS versus MSSP ACO track number 2, and the next generation ACO model A. And across the top, okay, so these are all annual, 3-year average annual gain or loss, okay, as a function of the quality achievement from 0 to 100%, as well as the cost achievement. And the cost achievement is where it's really the percent that you're above or below the cost benchmark that is imposed upon you by CMS under these various programs. So for example, this 4% up here, for this row corresponds to the that corresponds to the actual amount of expenditures by Medicare on your attributed patients for the cost component of MIPS, the actual being 4% lower than the benchmark. Okay, so that's a good thing. And then these negative numbers are bad, where you're spending more, or that the patients are incurring more costs, regardless of provider, and all under Part A and Part B, than the actual benchmark that you're going to be held accountable to under MIPS. Okay, so you can see these scales are all the same across all three models. Now, I want to point out some interesting differences among the numbers here when you really look at it. And let's just look at one example just so you fully understand how to read these tables. So for example, if I am right here at 50% quality and 2% of actual being less than benchmark, then under MIPS, I would be at $600,000 of upside. And on the top end here, you can see here with those input assumptions on the previous page, which again you can change yourself in the calculator, it's about 1.9 million of the upside, and then the penalty is actually not too bad, about negative $160,000. Okay, and the reason why it's more favorable in this case is because I actually set, it's not shown here, but I'll just actually here it is in the calculator. You can actually set what are your assumed achievement levels for the other two categories of MIPS. And so you see here, I've actually set those to be pretty high. If I set the MU achievement under MIPS to be 25% and maybe CPIA, the clinical practice improvement, to like 25%, then you're going to see a lot more red appear here. Okay, but that's why it looks favorable in this case. It's just because of the assumptions I picked. All right. Okay, so that's the MIPS. Now, if you look at the shared savings ACO, now there's a couple interesting things here. So first of all, you can see there's this band in the middle, okay, between plus minus 1%. And basically what this reflects is the fact in the shared savings program is that you can opt in to a certain minimum threshold of savings or losses that you have to cross in order to really start sharing the savings and the losses in a big way. This $500,000 that you see here is just because this Track 2 ACO, because it's risk-bearing, does automatically get that 5% APM bonus. You know, if we interpret the legislation correctly and the draft MIPS rule validates what I'm saying, and that you actually are an eligible APM if you're a Track 2 ACO, that's why it's a solid $500,000 all the way through here in the middle. But once you go past those triggers, which in this case is set to 2% in the assumptions, and again, you can change that, then suddenly you have a stair step, and it looks a little bit very kind of binary, you know, like the way in which we see value-based modifiers today. And you can get very substantial upside, but you have to save a significant amount. It's really hard to move even a few tenths of % on $200 million, okay? But you also have a significant downside too. It's a lot more of a sudden change, and there's a more gradual change horizontally with the quality score, as you might expect. It's really all primarily that cost savings that is, or loss, is really driving the major changes here. Now look at the next generation ACO program. It basically puts even more at risk, upside, downside. You compare these two endpoints, the top row and the bottom row here to the top row and the bottom row under the shared savings, the MSSP ACO program. The other thing you can also notice in under next generation is that there is no minimum threshold to trigger shared savings and losses to be paid out or incurred by the ACO. It looks a lot smoother here. There's no valley in the middle. There's no plateau in the middle. And that's another structural difference between next generation ACO and shared savings ACO that you can really consider in looking at those May deadlines ahead of you in terms of which one might be, you know, more in line with your strategy. You know, I played around a couple numbers in this calculator. It's absolutely fascinating to see how this comparison really changes among these three as you tweak up those assumptions. And there's certain parts of the application process for ACO where you have to make certain decisions, such as which track, you know, what type of trigger level you want. And this calculator hopefully can provide you a little assistance in running those scenarios, you know, fairly quickly, at least at a high level, so that you can maybe make a bit of a more informed decision. Now, obviously, this is all use at your own risk. It's Well, those in the calculators. Use at your own risk. We're not lawyers here, but hopefully it can be helpful to you. All right, so it looks like we got 20 minutes left. And I know we got a bunch of questions coming up. Let me just wrap here. Key takeaways, again, with just to summarize, that whole example I showed you probably was with the simplest possible ACO. Really from that scenario, you could see, like we said, that from a risk standpoint, this is the order of things. Dollar standpoint, tracks in this particular case. That'll change if you change the input values, and you can do that on your own within the calculator. And, probably one of the biggest levers is, again, this is only for one participant TIN. If you now had multiple TINs, such as 10 different TINs under the ACO, then the amount of the shared savings is going to change proportionally. Okay, except for that bonus is something that, every TIN will get its own little 5% bonus on its Part B. So, for example, if we had 10 TINs instead of one TIN, if you look at these numbers here, 10 TINs instead of one TIN under the ACO, these numbers would roughly be cut down by something like a factor of 10. Okay, you'd still have the $500,000 here buried in there, but this number really goes down by something like a factor of 8 or 8 to 10, and that starts to look small for a shared savings ACO relative to the topmost upside of MIPS for that very same participant TIN, where this is all accruing, this 1.9 million is all accruing to that one participant TIN, whereas 1/8 or 1/10 of this, 5 million, is what would be accruing to the participant TIN. That's 1 out of 10 different TINs under the ACO. Okay, so you can see how these numbers relative to each other can change drastically with the assumptions. I encourage you to play around with that, and we'd certainly welcome any feedback, any kind of enhancements you think could be made, or whether positive or negative feedback. We're always very open to that. Okay, so last is the resources here. That's where you can get the calculator. You can also Google MIPS calculator, and believe it or not, as of today, we're #1 on Google for the term MIPS calculator. You'll find it there. FAQ has been very popular too. You can Google that, find that out. Sign up on our website if you'd like to get emails about other tools to be releasing throughout the year. And again, all the webinars are posted. And we have this LinkedIn group that now is about to hit 140 members. And that has grown about 40% in about the last 4 weeks. So I'm very happy about that. Hope to see you on there as well. And so I think, Carol, with that, we do have about 15 minutes or so left for some questions. I'll hand it back to you.
All right. We've got quite a few questions from the live audience. We've got a few that I want to take first from the registration process. So, Tom, let's get to our first question. Can you review again the deadline for submitting ACO notice of intent to apply? Do you hear me? Are you there?
Yeah, sorry, my phone actually dropped out. Ironically.
Oh, no worries.
Yeah, I'm now on my computer. I really apologize for that. I don't know why it dropped.
No worries. Did you hear the
question, please?
Yeah.
I didn't hear the question.
Sure. Can you review again the deadline for submitting ACO notice of intent to apply?
Yes, absolutely. So for the next generation ACO program, it is May 2nd of this year in order to be a next generation ACO starting in 2017. And for the Medicare Shared Savings Program ACO, that letter of intent is May 31st. So May 2nd for next generation, May 31st for Medicare Shared Savings Program.
Okie doke. That's coming up fast. Can you just real quick, I guess, in this is sort of a long, probably a long answer or a long discussion, but is there 1 or 2 factors for providers to determine where they should fall into, whether they should do the MIPS or the ACO? I guess using that calculator will help do that, right?
Yeah, that calculator will let you run financial scenarios for sure. There is one factor, however, that calculator does not cover, which often is one of the key considerations is how much is it going to cost for you to get into the ACO game, period.
Right.
What's the lead time? And sometimes, particularly if you start to involve a lot of TINs outside of your legal span of control, it can get very complicated because you basically have to have contracting between the ACO entity and all the individual participant TINs. And if not all of those participant TINs are your organization's TINs, then that means there's a lot of negotiation that can happen too, and that takes time and that takes resources. So there's a lot of startup cost things to consider, and I think some ACOs have done a great job of being able to manage that. Right now, I think if you look at the statistics, the ACO program is really, as a whole, is really continuing to try to find its way in terms of having a lot of providers that ultimately end up with shared savings. And there has been turnover within the program as well. And a lot of, CMS is very, very open about a lot of that, and there's been a lot written about that within the ACO community. And I think there are a lot, you all can learn a lot from actually looking and Googling things about ACOs. National Association of ACOs has done a lot of commentary as well, both on the positive as well as aspects as well as some of the areas for opportunity. So a lot of other considerations, but the financial piece is obviously one where people like CFO and others, just from a pure reimbursement standpoint, is obviously very important to get your hands around as well.
Can a provider be penalized if the MD on an individual basis qualifies, presumably for MIPS, however the ACO does not?
Yeah, so one way I interpret that question is you have a provider who is falling under both an ACO as well as under MIPS.
Right.
And that could be because of low volume threshold. It could be because of the ACO not being deemed an eligible APM entity because it's not taking enough downside risk. In those cases, really that one provider from a quality reporting standpoint will be, because of the ACO membership of that provider, that GPRO submission under the ACO program, that will represent the quality performance for that provider. So now under MIPS, and again, we'll see a lot more about this in the draft MIPS rule, and there might even be some modification of what I said in terms of what the draft rule, MIPS rule, might say about that. There might be some carve-outs to what I just said there, so I do want to make that clear. But once you have the PQRS, generally once you have the PQRS measures submitted through really any one of these branches, it tends to be universally used by the different value-based programs that might need to have PQRS measure values for that, representing that provider. So you absolutely could have a case where, the provider, could be penalized under one program, but actually not get penalized under another program, or maybe even because they're along for the ride with other providers, maybe even be bonused under one program, but maybe not do so well in another one. The quality benchmarking could be different. There's a lot of factors that go into the answering that question. So that not a perfect answer, but it's a very complex set of factors you got to look into to really fully answer that question.
You mentioned the MIPS rulemaking, and they actually announced at HIMSS, CMS did, that they expect the final rule, I believe, in April on MIPS.
Yeah, somewhere in that April or in the few months after that, but they're moving pretty aggressively to get the draft rule out. That's really what we've heard as well.
Right. Do next generation ACOs, which are risk-bearing, count as an APM, same as MIPS ACOs are?
So I think there's a high likelihood. Again, I don't want to speak too out of turn before the draft macro rule comes out, where it will actually be defined. But if you look at the actual language of the legislation, right? In fact, I'm going to splash it up because that's a very important passage. I don't know if Carol, you can flip back to that slide where I had the screenshot of the legislation. But on there's key phrases around, it's got to be risk bearing to more than a nominal extent. So I take it has to be at least greater than 0 in terms of the amount of downside risk you have. And so I think there is a very great likelihood that the next-gen ACOs will be deemed an eligible APM entity.
Here it is.
Just based on that. So actually, Carol, it's a little bit further up. It's where I had captures of the actual macro legislation and with some parts highlighted. That's the one that you want. It's almost a little
almost at the star. Hold on.
Yeah, oh, there it is.
There it is.
With the green and
Sorry.
yellow.
Yeah.
Green and the yellow. We'll go right back down to the green and the yellow. All right. So yeah, there you go. It's that language. It's got a lot of organizations like the National Association of ACOs really focused on that language. Interestingly, you can see that if it's under that last Roman double Roman letter 2, medical home expanded under section 115A, those are medical homes under the CMS Innovation Center. Okay, you can see that those guys don't have a specific financial risk requirement because it's you see how the legislation is structured here. It's if you're not a medical home under the innovation model, then you have to meet that financial risk requirement. And that's really where the question resides in terms of the ACOs out there. Does it really mean that those 90% of ACOs that are in the one-sided model, are they or are they not going to gain the MIPS exemption or not by virtue of either being an APM or not? You know, that's going to be something that is a very critical thing for CMS to have final conclusion on. But I think next-gen ACO is a very high likelihood it will be deemed an APM and would thereby be exempt from MIPS. But if you have providers within that next-gen APM that are not billing enough Part B in proportion to other sources of Part B payment through that next-gen ACO, then that provider could still also be subject to MIPS. So it's not a total black and white answer. It depends on the actual provider and what their numbers look like.
Right, right. Let me go back to where people can find that MIPS calculator. Sorry.
It's on the resources page.
It's on the resources page. There we go. All right. Yeah. There you go. If an ACO member is also part of a tax ID that is submitting their scores as a GPRO, how does CMS process that ACO member?
Yeah, that's a great question. Well, in a way, it's a bit of a dichotomy as described there, because if you have a TIN, if you're a provider in the TIN, and that TIN's filing through the GPRO mechanism outside of the ACO, then that TIN is definitely outside the ACO, because if that TIN were in the ACO, then the ACO's GPRO submission would actually be what actually represents the performance of that TIN. And so there's some logic on the CMS side that, okay, if the question was more like if you were a TIN and you somehow if you were a TIN under an ACO, but yet nevertheless you somehow accidentally submitted as an individual GPRO under the normal PQRS value-based modifier program, you know, what would happen, right? Now, I think I haven't actually looked in that particular scenario in great detail, but there is some error checking within the, you know, a variety of the PQRS reporting methods that check whether or not that TIN should really not be reporting separately. In other words, that there is an ACO, for example, that's representing the quality performance of that TIN, but that error checking may not be complete. You know, it might still be possible. I mean, there's other situations where you can have duplicative reporting. And generally what we've heard from CMS is in those cases where you have two sets of quality measures for PQRS representing the same provider, that CMS will generally go with the set of measures that is more favorable to that provider under the relevant program. Okay, but that's a very generic statement, and as we know, often when you get to very specific programs, you know, you could have overriding answers to that logic. All right, so at the end of the day, if you have doubts about it, call the CMS support desk and tell them your particular situation. You know, that's kind of generally what we've heard so far.
Do you have to be an ACO to participate in an alternative payment model, an APM?
No, you don't. In fact, that legislation we just showed, you could be in an innovation center medical home, you know, and that would qualify an APM. And there's a lot of activity now among organizations that have medical home models, whether it be specialty societies, whether it be NCQA, to really essentially try to argue for the fact that their type of model should be deemed an APM that's risk-bearing, get the 5% annual bonus, and then be exempt from MIPS if they really, you know, want to do that. On the other hand, there's other, you know, providers out there that they are really assuming that MIPS is going to be their path, or at least going to be their fallback path, and at a minimum, they've got to understand MIPS. In fact, we've had a number of ACOs approach us and basically say, even though they plan to be on the ACO program for the long haul, they still feel a compelling need to understand MIPS, not only because some of their providers may ultimately fall into MIPS, but also because of the uncertainty around the APM eligibility. Will their particular type of ACO actually be deemed an APM has yet to be determined, and there can also be time latency between the period of time in which CMS evaluates whether you're an eligible APM versus whether we're really even talking about the current performance year, and that, or is it a future year? You know, so there's enough where basically everyone is well served by understanding MIPS, regardless of whether you plan to be in an ACO for the long haul or not.
And that's really good advice, right? Will Medicare, because I mean, obviously, the final rule is coming up, but just like meaningful use over a number of years, things can change and be updated and whatnot. Will Medicare Part B providers be required to be either a member of an ACO or MIPS or NextGen, or can they continue to report PQRS on their own to Medicare?
Yeah, so what happened, that's a great question. It's often the point of confusion too, is that, the question is really around how is my world going to change, with January 1st, 2017. And with respect to MIPS particularly, remember that MIPS is actually absorbing the PQRS, VBM, and meaningful use programs. So what's anticipated, but we won't know more about for sure until the draft rule comes out for MIPS, is that MIPS is likely to basically inherit and adopt and leverage a lot of the existing machinery around PQRS reporting. So for example, if right now you can pick from 13, 14 different PQRS methods, then likely in that, at least that first year of MIPS, you're likely to have almost the same range of choices. All right, and all it's going to change on the CMS side is that there will be a new portal that you can actually go through. CMS is building a MIPS portal right now that might be like a different entry point in terms of getting your data through. And there's a whole lot of third-party vendors out there as well that are assisting with PQRS reporting. What we anticipate is that a lot of that machinery will remain largely intact, and that from a workflow standpoint, you're probably still going to be able to do the things that you have done. However, under the MIPS scoring system, that will be entirely new, right? So the fact that the PQRS measures account for 50% of your MIPS score from a quality standpoint, that is something definitely new that you'll have to get your arms around in order to hopefully be able to somehow predict, where you're going to be at with the MIPS score before you actually finish up the year.
Right, right. Where do we find more information on how to form or join a virtual group?
Wonderful question. Go to our FAQs, right there.
Right there.
There's actually one of them is around that. And if my memory is incorrect and it's not there, definitely reach out to us. The question we'll be very happy to answer. There's actually a specific set of passages within the macro legislation that describes the virtual group mechanism. And the MIPS draft rule will have a lot more detail on that. And we'll certainly be delivering in a webinar like this as well as in other venues our analysis of that draft rule when it comes out. So, definitely sign up and get the notifications from us, and we can keep you posted on that as well.
Right. So commercial ACO-like agreements with a downside could qualify a provider or IPA group for a MIPS exemption? I think that was sort of a
It is possible.
Question. Yeah, what you were talking about, right?
Yeah, it is possible, but there's still a minimum amount of Medicare-based ACO or APM action that has to happen. So in the macro legislation, it says in subsequent years under MACRA that a provider can really meet that minimum APM thresholds and thereby getting the exemption from MIPS if they not only have a certain percentage of their overall revenue be billed through a commercial ACO where that ACO also meets the definition of APM, meaning that probably has to have more than the nominal downside risk. That there's a certain proportion of that provider's overall revenue that has to be, and it's either at 50% or 75%, depends on the year. Or I'm sorry, yeah, it's either 25% or 50%, I believe. I have to look back again, but there's a minimum amount that has to be billed through that commercial ACO. But in addition, that provider also has to have at least 25% of their Medicare Part B also through some APM mechanism. So according to that macro legislation, is that you can't have a provider, who has is like billing $1, or $1,000 of Medicare Part B and has revenue of $100,000, and they're billing the other $999,000 some odd dollars through a commercial ACO. Then at least for that $1,000 they have at risk, that's not going to meet the 25% minimum
Right.
Part B, Medicare Part B threshold to be in an APM. And so that provider will fall into MIPS. So there's a lot of intricacies around that, and we will see more in the draft rule. And I have little doubt that that will be a subject for one of our future webinars too, because it's very complicated, to figure out that the APM eligibility, much less the MIPS eligibility.
Right, right. With that, we probably have to wrap this up. If we did not get to your question, and we didn't get to many of them, you can email Tom at tom@saignite.com. And of course, we will be back next month for another installment of the ABCs of MIPS. Tom, thank you so much for your time, and we'll see you next month.
Thank you, Carol.
Bye.
Take care.